everybody. We'll start with this important topic, which is preload assessment and assessment of preload responsiveness. I'm Xavier Monnet. I work in Paris, and I have no conflict of interest regarding this presentation. In fact, the first question is how to assess preload at the bedside. In fact, it's not that easy because physiologically, as you know, preload depends on the dimensions, the diameter, also the thickness and the pressure at the end of diastole of both ventricles. Nevertheless, in practice, what do? We assess preload through either the end-diastolic pressures, central venous pressure, LV end-diastolic pressure, or through the dimensions, for instance, the left ventricular diameter or surface. It means that, in fact, what we do in practice with pressures or dimension is only an estimation of the true physiological cardiac preload. In fact, we'll speak about the left side, the left ventricular preload, and we'll start with the LV and diastolic pressure. That's the main way the LV preload is assessed at the bedside, so I will insist on that a little bit. And first we have to move back to the basic physiology, and you know these pressure tracers with the aorta here, the pressure of the left ventricle in dark blue, and the pressure in the left atrium. Let's focus on diastole, on this zone here. And in fact, you know that at the beginning, the left ventricle relaxes, and you know that it's an active phenomenon. It consumes ATP, it's an active phenomenon, and this relaxation creates this decrease in the LV and diastolic pressure, and here the mitral valve opens. Then the left atrial pressure at that time increases. Then during the ventricular feeling here, there is only a very small difference in pressure between the atrium and the left ventricle. And at the end of diastole, what happens here? The left atrial contraction. What it means is that at the beginning and at the end of diastole, there is a pressure gradient between the left atrium and the left ventricle. And so with Doppler, as you know, we measure the velocity of the red blood cells. It means that we will assess these pressure gradients, and we will see these E and A waves, E like early and A like atrium. And this is what you'll do at the bedside and during the workshop. Okay, this is the explanation of these E and A waves. How is it useful to assess the LV diastolic pressure and the LV preload? In fact, it's intuitively easy to understand because compared to the normal pattern, you easily understand that if the LV preload is increased, it means that this point here is elevated. It means that the E wave is higher and much higher than the A wave. In other words, an increase in the LV diastolic pressure creates a higher E over A ratio. Okay, so we know how to assess the LV and diastolic pressure. Nevertheless, there is a problem. And the problem is that the amplitude of the E wave is influenced not only by the left ventricular preload, but also by the left ventricular possibility to relax. And again, you easily understand that if there is a relaxation impairment, it means that the slope here of the LV pressure is flatter. It means that the pressure gradient at the beginning is lower. And this creates a lower E over A ratio. And so the problem is that if you have both an increase in the LV diastolic pressure and an impairment of the LV relaxation, you then know how to assess the LV preload through the E/A ratio. In fact, the solution to solve this problem comes from the mitral annulus, because you easily see that during contraction, the plane of the mitral annulus moves back and forward. And so it means that if you look at the velocity of this mitral annulus, you see that it decreases away from the probe at the beginning of diastole, and by contrast, then it decreases again during the left atrial contraction. Okay, and this is the continuous motion and cyclic motion of the mitral annulus. Also, intuitively, you easily understand that the velocity of this motion is related to the LV relaxation. And if the relaxation is very active, then the early velocity is very high. How do we assess the LV velocity of the mitral annulus? And for this, we use a very specific mode of Doppler, which is not color Doppler, but color Doppler of the walls, not of the blood of the left ventricle. And this is called tissue Doppler imaging, just different settings of the machine that are automatically set on the machine. You just have to click on a button, and at that time you record the low velocities of the walls and not the high velocities of the blood. It means that if here you measure the velocity here of the mitral annulus, you can assess with Doppler these true velocities, early and late, of the mitral annulus. They are called not E and A, but E prime and A prime, to differentiate, of course, from the mitral flow waves. So, how is it useful? The E prime is determined again by the LV relaxation. It means that the E wave, as we've seen before, is determined by the LV filling pressure and by the LV relaxation, and that's our problem. But the E prime wave is influenced by the LV relaxation. Then it's easy if you divide the E over A, the E wave by the E prime wave, you obtain a criterion that reflects the LV filling pressure. And this is the reason for this E over E prime ratio that, of course, you know and you heard about that already. This is the reason why the E over E prime ratio, or E over EA ratio, that's the same, reflects the LV filling pressure, and you will see during the workshop how to measure that in practice. You'll see also that below 8, it means that the diastolic pressure is not elevated. Above 15, it means it is elevated. And so the first thing you see here is that there is a large gray zone, a very large gray zone between around 8 and 15 or 12, where you cannot say whether the LV filling pressure is elevated or not. And this is a big problem. Then you can also assess the LV and diastolic dimensions. I will not insist on that because it's the source of many errors. Because to measure the LV and diastolic dimensions, you will measure either the area or the volume. For instance, with the volume, you will use the Simpson method, the same you will use to assess the LV ejection fraction. So it will ask you to measure the diameter of the left ventricle in 2 different planes and the length of the left ventricle, and automatically the machine will measure the volume with the Simpson method. And this gives you the volume of the left ventricle, which is again a marker of LV preload, but again, it is more difficult than the E over E prime ratio, and it's the source of more errors in measurement. Okay. then there are two limitations to these markers of preload, and especially to the E/E prime ratio. First, as we have seen, there is a large gray zone. Echo is not very precise to assess the LV preload. And the second limitation is that this measurement of LV preload does not help you predict fluid responsiveness. It means that if we want to insist on some important messages, the first is that LV preload can be assessed by end-diastolic pressure and area volume or the E/E prime ratio, but it is not very helpful in practice because it does not allow you to test fluid responsiveness before giving fluid. Let's speak about now fluid responsiveness and what's the principle and what's the problem. As you know, it's all related to the Frank-Starling relationship, the relationship between stroke volume and cardiac preload. Because when you give fluid to a patient, you increase the LV preload and the right ventricular preload also, and you expect that stroke volume and cardiac output will increase in response, okay? So in fact, you use the Frank-Starling curve at the bedside. But here there is a basic and very important problem, is that there is not only one Frank-Starling curve, but a family of curves which slope depends of the left ventricular contractility. And so you easily see that a given patient with a given volume expansion with the same increase in cardiac preload could result in a positive or a negligible response in terms of cardiac output. One says all patients do not respond to fluid administration. That's always something very important to bear in mind because, in fact, if you don't try to predict what's going to happen, only half of your patients will respond to your fluid administration by an increase in cardiac output. You've heard about that, I'm sure. Then how could I know before giving fluid that my patient is going to respond to fluid administration? And how is it possible to do so with echocardiography? The wrong way is to use the static markers of cardiac preload, the equivalent of the CVP. And of course, you know that CVP is very bad to test fluid responsiveness. And the obvious reason comes from the basic physiology, because it's obvious that one given value of cardiac preload does not predict fluid responsiveness. Again, it's basic physiology. What are these static markers of cardiac preload? It can be the central venous pressure, the pulmonary artery occlusion pressure, or with echo, the static markers of preload we have seen before, E/E prime, LV, and diastolic dimensions. All these variables do not allow you to predict fluid responsiveness. It's been shown by many studies. For instance, this one, you see that there is no difference between responders and non-responders to fluid administration in terms of E/E prime or LV and diastolic dimension. You cannot use the E/E prime ratio to know whether your patient is going to respond to fluid administration. Again, it comes from the very basic physiology. Always important to keep in mind because it's still very surprising to see how many colleagues still use such static markers of preload to test fluid responsiveness. And you know there is a huge amount of studies showing that CVP does not help for this purpose, and still many colleagues still use it anyway. Then how is it possible to do so with echo? And we'll see together 5 different methods. In fact, the idea is that we will test the Frank-Starling curve at the bedside. This is what's been called the dynamic assessment of preload responsiveness. The first method is to use the respiratory variation of hemodynamic signals. Indeed, what is the principle behind? The principle is that, as you know, in a patient under mechanical ventilation, each insufflation increases the intrathoracic pressure and so decreases the preload, tends to decrease the venous return, you agree? So it means that mechanical ventilation is associated with cyclic changes in cardiac preload, okay? Then you just have to look at the result on stroke volume. If mechanical ventilation results in no change in stroke volume or in arterial pulse pressure, it means your patient is not fluid responsive. If mechanical ventilation induces large changes in stroke volume or arterial pulse pressure, it means your patient is fluid responsive. If you have an arterial catheter, it's very easy because it automatically calculates this pulse pressure variation and it's displayed on the monitor. But if you don't have an arterial catheter, then you need to assess stroke volume in a different way. How is it possible to assess stroke volume with echocardiography? With echo, we will measure the velocity time integral of the LV outflow tract flow. In fact, you will do that also during the workshop. We will record the velocity of the blood just here, just before the aortic valve in the 5-chamber view. And we will record a negative signal, and the velocity time integral of this Doppler signal, the VTI, velocity time integral, is proportional to stroke volume. Okay, assessment of Doppler, you will trace the contour here of this signal, and it will automatically display the VTI, calculate the VTI proportional to stroke volume. And so to assess the respiratory variation of stroke volume, you just have to assess the cyclic changes in this signal. Okay? And it's been shown by not so many studies that it allows you to predict fluid responsiveness, and the threshold value is 13%, around 13%, not far from pulse pressure variation thresholds. Okay, this might be something we could use. Nevertheless, as for pulse pressure variation, the same. There are some very important limitations. You cannot use that in case of spontaneous breathing activity, in case of cardiac arrhythmias, or in case of ARDS because of the low tidal volume and because of the low lung compliance. In these situations, it is not possible to use PPV, stroke volume variation of the VTI with echo. And you will agree with me that the problem is that it's not uncommon, and especially in the ICU, so many patients are ventilated with low tidal volume, are not deeply sedated, and are arrhythmic. So respiratory variation of VTI or Vmax is not valuable in case of arrhythmia, spontaneous breathing, and ARDS, and that's, again, an important message to bear in mind. It means that if we want to construct, to build a very simple algorithm, should I give fluid, the first question is, are there arrhythmias, spontaneous breathing, and ARDS? If no, I can use the changes in VTI. If yes, I need something else. What could it be? It could be perhaps the changes in the diameter of the vena cava. The principle behind is a bit different, and the main reason why the vena cava varies is that if blood volume is low, ventilation will easily crush the vena cava. By contrast, if the patient is full, ventilation will not change the diameter of the inferior or superior vena cava. And with echo, it is possible to measure that. You will see how it is possible, and to assess these changes in the diameter of the inferior vena cava, and with transesophageal echo of the superior vena cava. And some studies, not that much studies, but some studies show that these changes in the vena caval diameter allow you to test fluid responsiveness before giving fluid. You can do that again with the inferior vena cava. You can do that with the superior vena cava with transesophageal echocardiography. By the way, you need a transesophageal echocardiography. It's easier, of course, with a transthoracic echo. By the way, also keep in mind that if you have an arterial catheter, it's the same, or even better and easier. Nevertheless, if there is no cath, you can do that with echo. Is it useful here? In fact, no. 2 points. First, it's likely that these criteria, superior, inferior, are not that good to test fluid responsiveness. A very large study, and you see that the area under the RAC curve, that's here in purple here, is low, in fact, in real life. Not the same than pulse pressure variation as demonstrated by so many studies in the literature. And the second point is that it shares almost the same limitations than pulse pressure variation. Not the problem of cardiac arrhythmias, but spontaneous breathing, of course it changes without indicating fluid responsiveness. Very important, it's always surprising to see some colleagues assessing IVC diameter changes in patients with spontaneous ventilation. Of course, if the patient breathes with a strong effort, of course it varies. All of us had no variation in the IVC diameter tonight. We were sleeping, but we were fluid responsive. All depends on the respiratory effort. And if the patient is not ventilated with sufficient tidal volume, you cannot use it. So again, it shares many limitations with PPV or the PPV of echo, except of cardiac arrhythmias. So the third method you could use is another one, and it is the passive leg raising test. Of course, you've heard about passive leg raising. The principle is very easy to understand. In a patient that you move to the passive leg raised position, you induce the transfer of some blood from the legs and, more importantly, from the splanchnic compartment toward the cardiac cavities. And so it's a reversible, not fluid, but preload challenge. In fact, it is a way to test the Frank-Starling curve at the bedside. This is what's called dynamic assessment of fluid responsiveness. Does it work? Yes, many studies have shown that it is useful, included in this meta-analysis, and there is another one that's been published with a number of patients. You see good area under the RAC curve, and it's likely the reason why it's been included in the last recommendations of the Surviving Sepsis campaign. Okay. How is it possible to assess passive leg raising with echocardiography if you have no other monitoring of cardiac output? Of course, you will look at changes in stroke volume during the maneuver. It means you will look for changes in VTI. You will measure VTI in the semi-recumbent position, measure it again in the passive leg raised position, and calculate the difference. And if it increases by more than 10%, it means the patient is fluid responsive. You give fluid, the patient will respond to fluid administration. Many studies have shown that, and you can say it is reliable. So it's something we could use in such instances, and also in the other ones, of course. Another method you could use is the respiratory variation of stroke volume, but induced by occlusions of the ventilation, of the ventilator, in fact. The principle of the end-expiratory occlusion test that we described now years ago is based on heart-lung interactions again. As we've seen, during tidal ventilation, the venous return tends to decrease at each insufflation. So, if we stop mechanical ventilation at end expiration, we stop the cyclic impediment in venous return, you agree? It means that for a few seconds, cardiac preload will increase. For a few seconds, the right preload will increase, so the left preload will increase, and if stroke volume increases in response to end expiratory occlusion, EEO, it means the patient is fluid responsive. Again, it's a way to test the Frank-Starling curve at the bedside. Stop mechanical ventilation, you increase preload, and look at the changes in stroke volume. Some studies show that it is reliable, and here you see that in this study, the continuous cardiac index measured by pulse contour analysis, the threshold was a 5% increase. Small, so you must have a precise technique. It's very easy to assess that if you have a continuous measurement of cardiac output. You stop mechanical ventilation at end expiration and look at the changes in continuous cardiac output displayed on the screen, so it's very easy to do. How is it possible to do so with echocardiography? Now, you know, we will look for changes in VTI. This is what we assessed in this study with Mathieu Josviac a few years ago. It's been published at the beginning of this year. We expected that during end expiratory holds, the VTI would increase more in responders. But we also performed some end inspiratory holds, and we expected that contrary to end expiratory holds, during end inspiration, for a few seconds, preload would decrease, and so it would decrease cardiac output more in responders than in non-responders. So we expected that stroke volume decreased more in fluid responders, and so we expected that the total changes induced by end expiratory and end inspiratory would be larger in fluid responders. We observed that it was, I will pass that, we actually observed that during end expiratory holds, more change in VTI in responders. During end inspiratory hold, more change, larger change in fluid responders. And so the total effect was larger in responders. Why did we add this end inspiratory hold to the end expiratory hold we already described? The area under the RAC curve was good for end expiratory changes, but the threshold was 4%, which is far below the precision of echocardiography, small changes that echo cannot measure. If we added the effects of end inspiration, the area under the RAC curve was the same, but the threshold was higher and more compatible with the precision of echo. Anyway, passive leg raising and expiratory occlusion tests, or end expiratory and inspiratory occlusion tests, are accurate preload challenges that you can use with echo. It's much more convenient with continuous cardiac output monitoring, but you can do that with echo. Something else you could use is the fluid challenge. The problem with the fluid challenge is that, of course, if the patient has many hypertensions in the day, if you perform fluid challenges, at the end of the day, the patient will have received a very large volume that did not increase cardiac output. That's the inherent problem with fluid challenge. This is obviously fluid overload. You can do that with echo, by the way, assess the changes in VTI. Nevertheless, some colleagues tested a mini fluid challenge with only 100 milliliters of starch. And they showed that the changes in VTI with echo were good to test fluid responsiveness. Nevertheless, small infusion can only induce small changes in preload, and so small changes in VTI. And the threshold here was in fact a 6% value, again below the precision of echo. So they had to artificially increase the threshold to 10%, and by increasing this threshold, they were above the precision of echocardiography. It means that with this mini fluid challenge, you need a very precise measurement of cardiac output. I'm not sure that echo is precise enough to assess so small changes, so it's the reason why I think that the mini fluid challenge requires more validation, but is not sure that echo is precise enough to assess its effects. Thank you very much for your attention.